متشكر قوي يا احمد على المقدمه رائعه، وربنا يسهل في الفتره اللي جايه دي اقدر اوصل معلومه امنه لكل الناس. In English, it's very nice for me to be here to sharing الحكمة in these educational programs, especially in something which is related to our activity, which is endoscopy. I try to put some things which I hope to be beneficial to everyone. Ahmed said guidelines. There is no guidelines now. It's a guidance. It is something to guide you, and nothing to be follow them. And I will start now by sharing the screen for the lectures. Yes. So I think all of you now have the screens. This is me, and I send guidance in endoscopic procedure during COVID-19 pandemic. These all the papers with you. I think the Al-Hikma will send you all this video. So what I get all this information from all these articles and review. So it is not my experience of some written in the last months. All these papers written in about 1.5 months. You imagine there are 2,000 to 3,000 papers in COVID and maybe about 500 on GIT and endoscopy. And this is all the society which I get all the information from this. So it's a huge amount of knowledge which I try to work it to be near to you and to be also in a scientific and educational manner. What's my advice? What's not advice? What's the advice endoscopy team according to all the data which I showed before? This is a very nice COVID-19 pandemic through the lens of gastroenterologist, looking for the silver lining. Before I don't read these papers, I don't know what's mean by that. Looking for the silver lining. What's mean by silver lining? Silver lining, it is the hopeful side of situations that might seem gloomy in the surface. Every cloud has a silver lining, mean that even the worst event or situation have some positive aspect. We can still ensure our success, becoming well-trained gastroenterologists, working together, taking advantage of unique opportunity, formulate novel solution to the new problems, being innovative, always looking for the silver lining. So you know now, meaning that what's mean by the silver lining, that this is mean that every event has a positive effect. What's the challenge of the medical staff in the era of COVID-19? You have some effect on your personal life, family, social life, some effect of your professional life. This is a personal life. Second one, a professional life. Work, environmental, education, conference, finance. This is a time that we can still present at the united front in fighting the pandemic, while simultaneously maintaining a moral. This is very important. There is a clean and urgent plan needed for endoscopy activity over the coming week and months. It is very difficult in this challenging time to decide what is the best for the patient, the population at large, and healthcare staff. Be aware that this advice may change rapidly as we will update it. Everything is updated very rapidly, especially as a further national update and the advice are announced. Situation conformity evolve rapidly, and this advice may change from day to day. So clinician and managers, first thing, restrict the number of staff in the room for all procedures. restricted the number of staff enrolled for all procedures, no trainee, limited advanced endoscopy cases to small number of very specialist consultants, assess the stock of consumable and device daily without panic. So you assess your stock of consumable and device, but without panic. Consider alternative for diagnostic testing like calprotectin, fecal occult blood, radiology, and something like that. And also what's called telephone triage. It is with a contact telephone with the patient to give him a referral after 2 weeks or something like that. What's your decision when you are in endoscopy? All of us are gastroenterology, are endoscopist, or hepatology, or surgery, and doing endoscopy. What you need to continue, what you don't do, what you need to discuss. Need to continue upper GI and lower GIT bleeding, acute esophageal obstructions, foreign body or food polyps or something like that, acute cholangitis, jaundice secondary to malignant or benign biliary obstructions, endoscopic therapy for perforations and leak, symptomatic pancreaticobiliary problems, EOS drainage for necrotizing pancreatitis. This should continue. Patient with a time-sensitive diagnosis like evaluation, surveillance, treatment of pre-malignant or malignant conditions, staging malignity prior to chemotherapy. Urgent inpatient nutrition support for big or nasojejunal tube. Variations of GIT obstructions, stent placement for large bowel obstruction and the pancreaticobiliary. Cases with endoscopic procedure will urgently change the management, like IBD. This is a query, but sometimes can be needed. What to stop? Not defer until further notice. Until, as I said to you, it's something which is rapidly changing. All routine symptomatic referral should stop. Planned time, pneumatic dilatation for achalasia, elective surgery, like structure dilatation, ABC for Gaves, pneumatic dilatation, ampulectomy, bariatric endoscopy should stop. Low risk follow-up, low risk follow-up for esophagitis healing, gastric ulcer healing. Poor view, you cannot see it very well. Check post-therapy, EMR, radiofrequency, or pleurectomy, ampulectomy. So this is a low risk follow-up. So this should be wait and give him a dates of 2 months, 2 weeks, 3 weeks, 4 weeks, but don't make it as a routine. Also, the same surveillance of polyp, IBD, or Barrett esophagus. Not the time now to do that. Routine, non-urgent small bowel endoscopy. EOS for benign lesion, biliary obstruction, possibility of stone, submucosal lesion, pancreatic cyst without high risk future. So this is the cases which you don't do it now because of, I said you why. Other ERCP, a case of a stone with no recent cholangitis and stent in place. No need for emergency ERCP, especially with cholangitis, yes. Therapy for chronic pancreatitis. Patients undergo endoscopy or biopsy as a clinical trial. So any trial should be stopped now, or postponed now, because it is not needed. Motility procedures, esophageal manometry, ambulatory pH testings, and rectal manometry, all of these 11 things. So you should, I will return it very quickly, but you should don't do all that now, all that, 11. Still, screening and cerebral endoscopy in asymptomatic patients. Screening and cerebral for upper GI asymptomatic patients, including screening of esophageal varices in patients with cirrhosis. It's not, it can be postponed. Evaluation of non-urgent symptom or disease status where the procedure result will not indicate any clinical impact on follow-up, like endoscopy for non-alarmic system, EOS for intermediate pancreatic cyst. We should wait for that. Bowel screening program, what to do? Endoscopy is a major cancer diagnostic service. Urgent suspected cancer patient are assessed case by case basis. Pushing colonoscopy screening program for a period, pushing it for a period, push in front 2 weeks or 3 weeks. There also a favor of continuing at least for a patient less than 70 years or patients with ocular blood positive test may present a priority groups. There is some things that need to be discussed with the consultant. 2 weeks waiting for cancer referral should be assessed on an individual basis. Positive stool test, bowel screening, colonoscopy. It needs to discuss with the groups. Plan EMR or ECD for complex for high-risk regions. So this should be also discussed with the people. New suspected IBD or acute colitis, it needs discussion. So I said to you that some things should be stopped, something it should be continued for that reason, and something it needs discussions between you and your teams. Cancer stagings, single balloon endoscopy, ongoing transfusion dependent bleeding, suspected small bowel cancer on radiology or capsule endoscopy. So this is needed discussions. For patient needed interval endoscopy for obturation of the veal varices, post-acute bleeding, the individual of the patient needed to consider demand safety of delay, that's safety or not. So all of these things should be discussed case by case. So we have 3 categories, and you should put that in your unit. That what the category don't do it now, something you should do it, and something you need to discuss case by case. And this is very important. Why we do that? Help to flatten and delay the outbreak curve, minimize risk to other patient and staff. The risk of fecal transmission is not clear what is present, and it be possible during colonoscopy. Asymptomatic infected patients are known of the source of infections. So for this measurement, we try in this measurement to flatten the curve. Stock of standard and enhanced person protections. This is, you should remember this one, PPE are limited and should be priority for where can be. This is a problem. Decline staff availability due to redeployment, which is mean that the patients which working with you is go to another places, or they get infected, or they self-isolated, or they take child care for his children. So the staff is decreasing. So for that reason, we should look for these things, which is personal protection equipment, should be looked very carefully. The supply of the device and the consumer may not be guaranteed, as supply chain are placed under stress. Who supplies these devices are under severe stress now. This is the study which we are gastroenterologists that the digestive symptoms are common in patients with coronavirus. And these patients have a longer time from the onset of admission. Prognosis is worse than the patient without digestive symptoms. Clinicians should recognize that digestive symptoms of diarrhea may represent a feature of COVID-19. Index of suspicion be needed to raise early at-risk patients presenting with digestive system, rather than waiting for respiratory symptoms to emerge. At risk, patient exposed to COVID-19 positive patient presented with fever and digestive system, even in the absence of respiratory symptoms. This knowledge may help with early identification of cases, faster time to the treatment, and faster time to treatment and early guarantee and lower exposure to the stuff. However, still, large sample study are needed to confirm this finding. And it's a map to say to you, this is a cases with this one with digestive symptom as respiratory system, and this one without respiratory. But these small groups here, which is called digestive symptom without respiratory. So you can find some patient like that coming to you without any respiratory symptoms, so you should take care of that. This is something I like to put in my lectures now about this pandemic. Don't look for additional information in the internet. It would weaken your mental state. What's mean by that? Don't go every time and every 1 minute and every 1 second look from the internet how mortality, what's happening, what's something like that. Please calm. No need for additional information. This is another very nice thing. Avoid sending a very bad message, fatality message. Some people don't have the same mental stress as you. And instead of helping people by sending this message, you could activate pathology as the pressure for them. So this is outside the lecture today, but it's very important as a psychiatric point for all of us. We return again that upper GI endoscopy of all kind must be regarded as erythroid-prone procedure. Don't forget this picture. Erythroid-prone procedure. Provide appropriate mask and person protective equipment for the staff. Nearly all the experts recommended that the healthcare worker wore a N95 mask or equivalent equipment while performing an erythroid generating procedure. Erythroid generating procedure. So endoscopy is this type. So you should have a mask. There is some key questions for American society speak about how I treat patient was presented was positive fecal blood and who is asymptomatic. In most cases, colonoscopy can be considered non-urgent and be delayed for at least 4 to 6 weeks. So this is one of the questions. If the patient had an upper GI bleeding, duodenal ulcer, and yet you did endoscopy, and has been put on a BBI for follow-up, can I do this patient's upper endoscopy, a follow-up upper endoscopy to assess large gastric ulcer healing? Should be delayed to 4 to 6 weeks in absence of any other alarming symptoms. Should all emergent endoscopy intubated? Absent of other reason to threaten the airway, intubation is not indicated for all upper GI. Proper use of protections at that time is needed, especially N95 mask. The septic patient with unknown and non-obvious respiratory cause undergo USVRCB require use of N95. All upper GI endoscopy require proper personal protection equipment, including use of N95. Should procedure be performed in patients with intermediate level, such as iron deficiency anemia or mild dysphagia? Decision regard the cases by case and need to made on a case by case, taking into account resource availability, level of community infectivity, and risk of the patient. So here you should delay. You can delay according to situations of your country. What is the Department of Endoscopy should know? Patient management and risk assessment. Once a patient is scheduled for an endoscopic procedure, risk of infection should be considered, should be checked, and stratified individually. The day before the procedure, all patients are called by phone ahead and survey about symptoms of respiratory infection, and potentially reschedule according to the specific patient disease and the conditions. Use nurse direct triage, which is phone between the patient and nurse or a nurse protocol to specify the risk of COVID-19 using the following question. In the last 14 days you have a fever, sore throat, cough. All of you know about that. Respiratory symptoms. This can be done by phone. You have a family or case suspicion of confirmed cases of COVID-19. You come from an area with high risk of COVID-19. So this is a question can asking by the nurse for the patients before you coming to do endoscopy. The same triage protocol is to allow the endoscopy person to prepare the recipient of the patient. Check patient body temperature before entering in the endoscopy room. You should check all the temperature before that. Recalcify this patient with a temperature above 37 degrees. Based on this preliminary screening, patient can be classified as low, intermediate, and high risk, which translate to different module of infection control precautions. So classification of potentially infections, risk in patient undergo endoscopic examinations. We have 3 items. So by this, you can have 3 items, which is low risk, no symptoms, cough, fever, diarrhea, no contact with someone was positive for COVID, no stay in high risk area during the previous 14 days. It's a low risk. Intermediate, present with symptom, with no immediate history of contact with someone who was positive, none stay in high risk during the previous 14 days, or no symptoms, but contact with someone positive or staying in high area during the previous 14 days of infections. This is intermediate. High risk, at least 1 symptoms above, and one of the following: contact with someone who is positive or stay in area with high infections. So this is, you classify your patient to low risk, intermediate risk, and high risk. Then what you should do for each, you should consider that very good. If you have a low risk, what you do for personal protection equipment: surgical mask, hairnet, goggle, which is very important, single-use gown, gloves. This is for low risk. So this is a low risk. So everyone should have a personal protection equipment. But for low risk, it should be, you should have this one: single-use gown, gloves, hairnet, surgical mask. So if you have intermediate risk, upper GI endoscopy, consider a high risk procedure. So upper endoscopy, consider as a high risk procedure. It will go there. Lower GI colonoscopy, consider as a low risk procedure. It should be go in this area. High risk. So you should have N95 or FFP2 or FFP3. It is the same like N95. Hairnet, goggle or face shield, and I will show you how this is. Long sleeve, water resistant gown. You look here in the low risk, it is single-use gown. Single-use gown. Here is long sleeve, water resistant gown. And 2 pair of gloves. So 2 pair gloves you have it. And I will show you how to use it. So this is, you should classify your patients according to that, and use all this modality. So this is the high risk, this is the intermediate risk. Colonoscopy, it will go here. Upper endoscopy, it will go in this area. Look at carefully. A, which is low risk. Hairnet, you see it? Google, you see it? And surgical mask. And single use, that is here, single use gown, this one. All of you know about that. And the goggle and the gloves over the ground, which cover the wrist, here. So this is A. High risk dresses. different. You have a hairnet, you have the Google in the face or face shield, you have a long sleeve water resistance gown, and you should have N95 or FPV 2 or 3 respiratory, this one. So this is the difference between high risk and take care of the N95. It's equal to FFP2 or FFP3. It is the same. This is the company and this is another company. But this is for high risk and this is for low risk. And you should follow that, because the doctor who doing endoscopy, it's a very high risk, because as I said to you, there is oral generating procedures. Okay? And this is one mode of transmission, and the distance between you and patient is very, very close, less than 30 centimeters. WHO, what he said, because of optimize person protected equipment availability, you should coordinate the supply chain. You should minimize the use needed, who is needed, and you should use it appropriately. So this is the recommendation of WHO. Because to optimize, use it, not use it in nothing. So everyone, like if you look this again, you can choose what you can use that. So it's not needed to have N95 in low risk. Only you have a surgical mask. I said to you, I work as I can in all the paper to get this information, which it rapidly changes, as I said to you. Person protection equipment want to reduce exposure to hazard and cause workplace and injury. Person protection equipment include items as gloves, goggle, face sheet, respiratory protective equipment. One of the most important pieces of this is the mask. Because as I said to you, endoscopy, it's a resource generating procedures. N95 or other, which FFP2, FFP3 respiratory is protective device designed to achieve a very close facial fit and absolutely efficient to filtrate airborne particle up to 0.3 micron. This is very important. The edge of the respiratory are designed to form a seal around the nose and the mouth. WHO recommended respiratory protection for provider by using standard surgical mask. For the respiratory, for the providers, and they can use that. This is the recommendations of WHO, but for the endoscopy, no. All the person not directly in close contact with the patients, those on a charge of endoscopy infection, currently can wear surgical mask for the time. We strongly discourage, this is very important, even in the time of shortage of device, to reuse a disposable device. This is now, it is, you cannot do that. All of the checks that the equipment are sharing, are using has not expired because it will be comprised its integrity. Proceed with fitting test, and this is very important. I will show the pictures for me because it's not fitting too much after has been put on your face. So try to be test the mask before you putting it. In case of shortening or filtering mask piece, sporadic use of surgical mask is substitute is recommended. If you don't found N95, you can use one surgical. There is some paper or some people speak about using 2 surgical masks, but it is a discussion between me and about 23 doctors on the groups all over the world, which is emergent start, especially in New York, with a shortage, and in some area they can use 2 surgical masks. Endoscopy personal precautions and the dressings. Keep a reasonable distance from every patient during the step taken before the beginning of endoscopy. This is very important. It's mandatory to wash hand with soap and water or alcohol base and hand rub before and after all patient interactions. The minimal composition of set, the minimal of set of precautions of protective personal equipment for person endoscopy should be modified based at risk stratifications. So you should have that before you start your work. This is very important. Some of you or some said, I have it, but the problem is the sequence of putting and recovering. The first steps here, if you look here, is to put your hairnet. And then the second step, hand hygiene. The third one, after you make hand hygiene, third step, put a gown. And second operator should assist in closing up from the back. So this is the third one. The fourth one is to put the mask and should be fitted, should be done after putting on the face. Recommending fitting test to fit it's fit on you or not. And this is the fifth one. Alternative, you can use, if NPB or FPB are not present, you can use this surgical mask. The fifth step is to put the goggle, which is very important, this one, because the eye transmissions from air proceeding procedure or genetic procedure is very high. So this one. The third one, which I do that now very frequently, it is putting the glove. Simply put on gloves. One inner one is two pair. One inner. The first one cover your skin up to the rest. The second outer one cover the gown. So the second one, it cover the gown. The first one cover your skin above to the rest. So use two gloves. So this is very important. And I will show again here, which is easy. First and second, third one, fourth one, fifth and sixth. Believe me, this is a very important because you can contaminate yourself, you can contaminate your patients, and the patient can contaminate you if you don't use step like that. What's more important than that? This is me when I have this is 95, and it's a goggle, this is hair sheets, and this is a sheets. And I give this picture for Eddie, which I show you that they have two gloves here, and this is what's called face shield, which is like that. So this is what you should be have in the endoscopy rooms, and in the picture which I do. Removal. Maybe you said that easy to protect yourself by getting or dressing the personal protective equipment. But I think the most important is once you remove the glove, you have been completed. Hand hygiene should be performed again. A new pair of gloves should be worn. You remove your goggle or your face shield, touching them from the front, not from the front part which is contaminated by droplet or particle. Because if I remove my camera, if I move from here like that, it's nonsense. It should be removed from here like that, because this area is contaminated. So you can protect yourself, but at the end, you get all the infection. After glove removal, hand hygiene can be repeated. So I will show you, this is the steps of how to remove the personal protection equipment during COVID-19. So this is all, but I try to set it once by once. The first step is to make hand hygiene here with the gloves. Second, you remove the both gloves. After you remove it, third one, you make hand hygiene again. And after you make hand hygiene, you get a new one, only new one. So you have you take a new one. And then you remove your gown. And second one can assist from back for this one. So this is the first. So if you removal, it's like that. It's like this way. Like this way. And then after that, you remove your goggle from here, and then you remove your mask and avoid touching the front part, which can be contaminated. Avoid touching the front part, which can be contaminated. And then the eighth one, you remove the hairnet, and then you remove again the gloves, which you take it. And after that, you make 10th hand hygiene. So I repeat it again because this is very important. Because in removal, you finish the procedure. So you feel you are safe. Normally, when you reach your home or reach anything, you forget that everything you become relaxed. But during this time of relaxations, you will get problems. So this first one, hand hygiene, remove the gloves, silk and hide the hygiene, and then put another new one, gloves, and then remove your gown, and then remove your goggle, and then you remove your mask, and then remove your hairnet, and then you remove your glove, the naked one, and then make a hand hygiene. It is simply, but believe me, I have a papers which I printed for that, because I try to put this paper in everywhere. So it's a paper like that. So you can make it a very simple. You can make a paper from that and put in your endoscopy unit. I think all of you can see. I think these papers. Okay. Despite suggestion to perform a procedure in a negative pressure room is very good, but it's not in all endoscopy facility have that. So we recommend performing endoscopy in a negative pressure for high-risk patient in negative pressure rooms. We speak about patient dressing code. All patients enter the endoscopy should be invited to wear a surgical mask. That this mask must be replaced again once the patient has recovered from sedation and sufficient to maintain oxygen saturation above 90 on the room air. So this is another important for the patient dressing code. We recommended that all the endoscopy and reusable accessory should be reprocessed with a uniform standard of reprocessing procedure. At that time, it is very important to look for disinfections part of that. Again, I return it to the virus again. Isolate yourself from news about the virus. About the virus, not to speak about science, but about mortality, about incidents in the United States, incidents in Egypt, how's going in Turkey, how's going in Italy, how's the mortality. Try not to go very deeply, everyone met on that. Isolate yourself from news about the virus. Everything we need to know, we already know. So it is no need to look for too much about that. This is, I try every one of you take care of what about this slide. It's coming from one of my friend, Valerio, in Italy. What I cannot control. What I cannot control. How long this pandemic will last? Give a solution. Who will get ill and who will not? If life will return to normal. Other people choice. What business stay open and what stay closed. If anyone, when they find a vaccine, people reactions, who will not follow physical distance and socialization. What I cannot control. I cannot control all this yellow area. But remember, what I can control, my attitude, eye contact with people, my exposure to negativity, what I am grateful for, my routine, how I take care of myself, how I spend my time, what I do for fun, my reaction, what I focus on. So I can control on that. You cannot control on this area. Try focus here. Try focus here to survive this life. It's possible to listen to music at home and the pleasant volume, play with children, with telling them story and speak about future. You should have a future. You should have a plan for future. It is very important. Great thanks, warm regard. We're looking forward to having quick, effective solution to eliminate the coronavirus. Please stay safe, stay positive. Egypt will become very good, and I plan for the future. It's not advertising, but if I stop to plan, I will lose everything. I will lose my mentality. I plan. Maybe it will not done again in my life. Maybe it is still Corona at that time, but we should everyone have a plan and has a positive actions. And thank you for much to be with me. Thank you.
دكتور ابراهيم، في حد كتب سؤال وفي ناس رفع ايديها، لو حابب حضرتك بقى تسالهم على يعني هم حابين يسالوا، يعني حضرتك ممكن تفتح لهم باب السؤال.
طيب okay, I start to questions. So first I will go by the written questions. What type of mask put to the patients during endoscopy? To the patients themselves, surgical mask. So this is done. Need more? No, another question?
بليز لو حد عنده سؤال يكتبه في الشات، لان في ناس رفع ايديها يا دكتور ابراهيم.
Yes, but they can. How I can listen to that? I over for admin. There's another one. Ibrahim. What BPI? So another thank Dr. Ibrahim. Thank you. Second one. Why BPI not think about? Why BPI not talk about both? Very important. What's mean by that? Why BPI not about both? Very important. I cannot understand this question. You speak about BBI. BBI talk about both, very important. Why BBI not talk about? I don't answer. This is coming from George Helmi. From please where? This is another one. Please where we can find instrumentation how to use. Where we can find illustration how to put. As I said to you, these lectures will be on we're putting on the Facebook, and Hekma said to me that we'll put that so everyone can take it from that and they can copy it, because I think this is a very important question that everyone should copy it and put it in the unit and should insist on that. Second, if any patient's alarming symptoms and they will undergo highly indicated endoscopy, what to do? Shall I wait for radiant testing or proceed with endoscopy? I said you have cases. If you have cases you suspect alarming symptom of GIT, you put it in high risk, low risk, or intermediate risk. So according to these cases, you protect yourself. So in high risk patients, which I said you how to protect your patient in these high risk patients, and to test for COVID-19 testing. Yes, if the patients have a pulmonary symptom and they have everything, you should test. But at the end, if you need endoscopy, you should be ready to use a very high personal equipment for that device. Please, where we can answer that. Can we get recorded later on to our email? Is a question for Hikma. They need the lecture to send to their email. I think they will do that. They put it in the FaceTime, Facebook, and then everyone can take it, because the answer they needed these lectures by email to all of them. So I think
بليز دكتور ابراهيم ممكن تقفل الشير عشان حضرتك تكتبها للاودينس.
I see. Okay. Okay. This is okay now?
تمام يا دكتور.
So please, where we can find now, already we answered this one. Can we get recorded? Yes, they need a recorded webinar. I think Ahmed will email that for all of you.
Yes, it will be on our website, and we will send to you.
In the Facebook, I think so. Come on.
Yeah.
How to reuse sterilized accessory after? How to reuse sterilizable accessory after endoscopy? I said in my lecture that any accessory which is reusable, you can disinfect it by normal way. Any accessory which is not reusable, you should never use it at that time. You speak about problems of stock, but this is a very, very hazardous. Now, is disinfection of device will be different? No. The normal disinfection, use it. It is the same, but it can kill this virus. Different, I said no. What's the true about patient protection when made for hydroxychloride? If the truth that about BB made for hydroxychloride, this is a joke. That this is used since many years for many diseases. We don't speak about corona. So this is Persian protective, not made from hydroxychloride. It is joke from Baha Osman. Okay. Shall we, regarding any patient who undergo endoscopy, proceed as COVID-19 positive, even asymptomatic, has no history? I said in my lectures also that you have three categories of patients: low risk, high risk, and intermediate risk. But you should aware that asymptomatic patients of COVID-19 are huge. Nobody know about that. They have no symptoms, but you cannot test everyone coming to endoscopy. You cannot test everyone. So what you will do, if you look for my lectures, I put you a schedules how to be put the patient on high risk or in intermediate risk or low risk. So by this way, you can use the personal protections equipment right, but you cannot do for everyone. But you can classify your patients. If obstructive jaundice, may I delay the ERCP or necessary, or it's necessary for? As I said, this is a very good question, but already I answered that in the lectures. Muhammad Muqabil, I said there is no cases of obstructive. If you have an obstructive jaundice with cholangitis, you cannot delay. It is urgent. But if you have a suspicion of a stone without cholangitis, and have a stent present, and the patient is good, normal enzyme, normal ruben, you can delay ERCP. So ERCP is done if you have a cholangitis. If you look to my lectures very well, you will find the answer. Thank you very much. I think that last message is very important. You don't go to the more worry, uncertain, use about virus better. Keep in your protective measure at clinic and department. Professor Dr. Nasser, Abdullah, Alexandria University. Thank you, Nasser, for that. We try all of us that not all the lectures to be an medical one, but other to give you some positive things to go. Please, we need this lecture available today on our email. Many people ask Hikma to have this lecture today. Okay. Please, we need this lecture available today. Yes, okay. Thanks, Dr. Ibrahim, for the excellent session. You said that colonoscopy has a low risk. But what about the virus found in the fecal and affected cases and the waves recorded cases of Canadian cancer? Yes, I said yes. I said I put the colonoscopy. I put the colonoscopy like a case, and because of there is some areas that it can be transmitted. If you look for WHO, it said that any aerosol generating procedure can said that. And there's some paper speaking about presence of virus in the stools, and some paper present about what's you call the Clostridium colitis. So I put them as a low risk, which is mean that you put all the person protection. You have the goggle, you have the mask, you have the gown, you have the gloves. So I put everything, but I don't make that it is because I put them at a low risk. This is not me, but this is found in all the paper. It's low risk, but still low risk in what to wear, what to use. So use a protective measures also. No endoscopy without protective measure, but it changed from one to others. Both or over. Both or over shoes. You speak about over shoes. Yes, you should both or over shoes. This is absolutely right. You should cover your shoes. You are right. Please, we need the lecture as early as possible. Okay. Please, we need the lecture as early as possible. Okay. If there is any modified mask can be used by patients and the upper endoscopy pass through it. If yes, you speak about a mask and then the endoscopy go inside. But when this is meant, that still there are some air would coming out. So I think it's impossible because you cannot do that. You cannot do that. You can protect yourself by making this. You make a goggles or you make a mask. You can make a sheath, and I can if you excuse me 1 second. 1 second. This is a sheath. I have it, but I don't use it up till now. But this is the sheath, and all of you about that. But this we never use until now. But this is when when I do the cases was a very known to be a positive with fever and everything. So this is a sheath, which I cannot show all of these things. Please, can you find alternative of how to put the same questions? Ahmed will send the lectures. If any modified, we answer it. If there is any antibiotic taken by the patients, if there is any antibiotic taken by the patient on this quest, no prophylaxis. No prophylaxis. What's the best disinfection for endoscopy for Canadian man? For fluoride is good. What you use for your endoscopy by your disinfection, use it normally. It can kill everything. What you kill virus C and virus B, it can kill this virus. So there is no change for disinfection. The same can be transmitted by fecal-oral. It is isolated from. Yes, I said that because the patient. I said about these fecal transmissions or can be used for colitis. So during colonoscopy, they put that colonoscopy can make an erythroid generating procedures, and for a reason they said that personal equipment should be used, but not at a high risk. Can CBC before help endoscopy? if lymphopenia taken. Believe me, now, as one of my colleagues said to me that man, all the blood pressure now in Egypt have lymphopenia. I don't know why, because of the doctor written that. So you cannot depend that ask about. You, as I said in my lecture, you measure the fever, you ask 3 questions, and this is not, as I change the condition is very rapidly. And so it's guidance, it's not a guideline. So I get what I can from the person. So they said that you measure, you ask the patient 1 day before about symptoms, about traveling, about any connections, contact with any positive patients. You measure his blood pressures, measure his temperature. So this is what's written. But to give him blood pressure to do lymphopenia, no. When you can suspect a probable infection in patients presenting with digestive septum diarrhea, abdominal pain, when to say it's not a gastroenterologist, as possible, may be accompanied by fever. Yes, this is what happened in China about that patient come with fever and diarrhea. You should suspect infections by COVID-19. And at that time, you should refer, because this is symptom can happen before respiratory symptoms. This is outside our lectures, but I have many papers about that because I collected this endoscopy paper from about maybe 2,000 papers. So you should refer these patients. Maybe you should check for RNA, PCR for this one. Thanks, Dr. Ibrahim. What's the opinion? In summer, high temperature can reduce COVID to affect the temperature. There are many papers about that, but I said to you that I said in my lecture, don't go on the internet too much. Don't listen to everything. If you open now the WhatsApp and the internet, there are many thousands of things, temperature, shalawlaw, many things. We don't know what is right and what's wrong. What's right, we read all the papers which are already present. We use some experience. We should respect your health systems. You should respect your country and should follow that. According you are from Egypt, from Tunisia, from Saudi, you should respect the national guidelines put to you or the national instructions. This is now, there is no time for argument. There is no time that you should this not or not. There is a rule in everyone. Look for the website of World Health Organization. Look for the website of your Ministry of Health. Go in that reasons. This is the most important things in my opinion. Don't go to many speaking about that. If the summer, we don't know. It's a very rapidly progressing. As lymphopenia, I think it's high risk. Anyone has may have lymphopenia. So if one coming normal with no fever, no cough, no symptoms, no contact, not coming for everyone, and by chance you have lymphopenia, I don't speak, but actually I did yesterday an ERCP for a case with lymphopenia of 17, but has a stent in the post-transplant, and this is patients known to some people listening to me, and this patient had a lymphopenia, but he receive a neural, receive myfortic, receive many drugs for immunosuppressions, but he have occluded the stent. But when I looked at all his has lymphopenia. So lymphopenia, forget about that. It's a high risk, yes, especially if you have other things. But I will not go too much. For the fecal face shield can be washed, disinfected, or used. It is, as I said to you, this one is reused, but you can clean it or wash it or disinfect it and it's used. It's not for one time, but it's like that. It's not one for time use. So I can give my lecture, and this time it's Corona coming on the internet, but normally no. It is legal to postpone unnecessary endoscopy or endoscopic intervention till this panic ends. Yes, it's legal. It's legal like many things, because there is no necessity to do endoscopy and to get infected, to transmit infection to all the people inside the rooms without any hazard. People coming for has a parrot esophagus or has esophagitis, and he come for follow-up. So I give you 10 people. You don't make it as a routine. You should postpone for the immunity, for us, for your children, for your country, for your wife, for your mother, for everyone. So you can that everything it can be changed. We can, and sometimes you can do nothing. So in my opinion, yes, it's legal. It's legal. Not an patient coming to me. Patient come to me, which is coming for a heartburn, and give him a PPI for 3 or 4 weeks, and then he come again. But if I have a very alarming suspicions that vomiting blood, or he cannot eat, he has severe dysphagia, he cannot pass anything, these times I can do something. So, and this is not my opinion. This is opinions of hundreds of papers done. So we should follow what the people said and what we said in our country. So, in my opinion, it's legal, and I do that. No other questions is coming. I hope that I can benefit from these lectures. I hope that you can know some things. I very get impressed by the questions. Also, I get many information by your questions. My knowledge is increasing by your questions. So I try to give something to you, which I have learned, which I have studied since about 1 or 2 weeks about that. And also I get some information from all of you by your questions. And I hope that we meet again in lectures. And for some legal part, if you look for the first time of the website of Egypt Gastrohealth, I have lectures in Arabic about all these things. You can find that, but regarding the gastroenterology. There's another question coming, which Abdurrahman, thank you. Another coming, it is, dear Professor, thank you for the lecture. I have 2 questions because I joined late. He's still writing the questions. This is Muhammad Omar. What to do if you don't have excess PI? We use the same for many cases. No. You cannot use the same for many cases. If you don't have an N95, you can use a surgical mask. Why second glove after removal of already solid 2? Why second glove after removal of already solid 2? Yes, you don't look for all the lectures, Muhammad, because I said that you remove everything, and after you remove everything, you make a hygiene, and then you put another new one to remove your everything again. And this is better than you use your hand. But if you look to the lecture, you come coming late, you can understand what happened. And this is also present on the American Society and British Society of Gastroenterology. As land wearing, should I wear overhead as a land wearing? Yes, you should wear it because it is it's coming from the operating theater. You should wear it. If the doctor diabetic or hypertensive will go to doing endoscopy, this رفعت كامل. Yes. If the doctor is diabetic or hypertension will do endoscopy, I do endoscopy and I have hypertension. Very simply. Because I do endoscopy by all precaution, but I don't stop that. Because I don't do all the cases, but I do the cases which is already cases which already need me. Like I have a case since 3 days or 4 days. The case of obstructive jaundice, group of 19. Amylase is 2000, lipase is also very high. A severe cholangitis. If I don't make an ERCP urgent to remove the stones, it will be die. And they asked me to do that. I can refer to another one, but this kid's coming to asking about me. So I take the precautions and I go. And normally, I don't work like normally, but only in a very specialized cases. If you stop treat all the patients, what the patient will do? They will die. So I would like to thank the people on the front lines. I am not on the front lines, but there is another mini doctor on the front lines. They are very, very, we should respect them very good and should try to help them very good. But there is other people who do operations, who do sophisticated things. They cannot stop, because if I stop, what the patient will do? We let the patient to die. So we should work, minimize. I will never work on the front line because it's forbidden to work on the front line, but I can advise from behind. I can do some things which other people cannot do it, or I can do it better, or the patient ask me to. I still do many consultation by phone now, but I also make some consultation on a basis on interview, but a bit of precaution that every patient has a mask. It's sitting about 2 meters with me. I only see 3 or 4 patients a day, but these patients need only to be, some patients need to see you only, so they become calm. So this is now our time to help patients, because all of them are panic. So if you have something, but you have a big problem, don't make it, don't go. If you have diabetes, portal hypertension, you are very old and have problem, don't make it. So there's another questions coming. Thank you, Professor. Should I change the mask for every procedure at the same sessions? It's a very good question. No, the masks can work, to me, can work for 4 hours or 6 hours. I don't know exactly, but I can ask about that. But you can do, if you do 3 or 4 cases, you can have the same mask. Don't touch it again and leave that. So don't change the mask with every procedure. If you don't have 2 hour endoscopy or 2 ERCP, I use the same one. H. pylori, it's a risk factor for COVID-19. Huh? H. pylori infection is a risk factor to getting COVID-19. This is, I said to you what happened now. I dislike this question, or I like this question. Why I dislike? Because it's not now. I like it because now many questions about that. H. pylori has a factor for getting COVID-19. It is genetics. It is, now we should make the safety and look for other people to look for that, or to make a study on that. But now there are many speaking about many things related to that. Is temperature, is something like that. I agree to ask about that, but don't to go very quickly in everything. You will not finish. Compared surgical mask and NAB for different in potency protection of virus. N95 is better, I think, you before that. Compared with surgical mask with different potency protections, the answer is yes. Surgical N95, it's more potent, but as you use it when you use it when you're very high risk. But use a surgical mask for low risk, and also surgical mask for all the people working or the working in the hospitals, which have no direct contact with the patients. Again, this is the WHO recommendations. Infection control staff advise always to dispose of the mask must be outside the patient's room. And infection control staff advise always to dispose the mask last outside the patient room. Cannot understand, but you should after you use a mask, after using a mask, you should put it in a basket, and then you close it, and then you put it in a closed basket again. But you, as I said, if you use one, and to make a round, not with every patient during endoscopy. Use it, and then you continue it, because you are afraid from infecting yourself. But if you're afraid that some patients with virus at itself, you can use one by one. Now I think we have no questions. Now I think the people. I am not tired, but the people become tired. The Hikma also is tired. So for me, I hope that everyone can benefit from this one. I hope to be with you. And if you have any questions, you can ask to Hikma, or you can ask my email, which is Ibrahim Mostafa @egyptgastrolab.com, and he is to get it. And you can ask me, or you send the questions to Hikma webinar, and I sure if they send me the question, I will answer it, and they will reply to you.